Everyone. Thanks for attending our annual CARE4U2 presentation and our online CEU credit hours. My name is Elizabeth Chips. I'm a licensed professional counselor in Missouri and Kansas, and today I am presenting on increasing safety measures and awareness in the mental health workforce. I am the site lead at our Prairie Village office, so every quarter I do safety meetings for our staff, and so I was tasked with the CARE4U2 committee with talking with you today about some different ideas around understanding different safety risks that mental health workers face, and also some of the proactive measures that we can take to create a good safety plan and to understand how mental health workers can protect themselves more effectively in regards to safety and wellness in their offices. So our objectives for today are to review the statistics of workplace violence, or WPV, for mental health professionals. We're also going to discuss the potential risks for mental health workers that are unique to the mental health field, and then work to identify some policies and procedures to help keep our offices a little safer, and then discuss potential screening instruments that you can use in your assessment or ongoing care. Then talk a little bit about some of the ethical considerations that come into play with workplace violence incidents. And then we're going to spend just a little bit of time at the end talking about other safety concerns like weather, fire, or public health emergencies, and just kind of having an idea around what some safety measures for those particular instances could look like. So just a quick disclaimer, I am only a licensed professional counselor. I obviously am not a legal expert and ethical expert. So this presentation is really just to give you some information, get you thinking about your own office space, and then who you want to connect with to create a really good policy around workplace violence and safety in your office, and just kind of give you some ideas and some thoughts to think about while you're creating that plan. So before we get started, it's important to understand what we're talking about in regards to workplace violence. A lot of times we think about the physical portion of workplace violence, assaults, or being attacked by a patient or other community member. But workplace violence is more than just that. So it consists of behaviors or threats, singular or repeated, that cause physical, psychological, sexual, or economic harm. So workplace violence occurs in all mental health settings, in hospitals, private practices, across the board, and can include violence from clients, coworkers, and the public at large. And workplace violence exclusively happens, obviously, while you're performing your job duties as a healthcare worker. Just some different types of workplace violence that were mentioned in the definition are going to be physical, psychological, economic, and sexual. Physical, again, is kind of what we think about when we think of violence, assaults, homicide, any kind of physical attack. Psychological workplace violence would include intimidation, verbal abuse, bullying, any kind of violence that affects our mental health or our psychological functioning. There's also economic workplace violence. That would be threats to your livelihood, threats to your license, to your job, that would create an economic difficulty for you. And then sexual workplace violence includes sexual harassment and sexual violence. For mental health care providers, the most common type of workplace violence experience is going to be psychological, verbal abuse specifically. So those are, while we think more of assaults being the primary focus of workplace violence, it's really the verbal abuse that is most commonly experienced by mental health professionals. We can kind of divide workplace violence even further into different domains, what they call mega violence and micro violence. So mega violence is going to include mostly illegal acts, things that have a significant effect on the victim, assaults, threats, other illegal behaviors, stalking, verbal assault and harassment. Those types of things are going to be considered mega violence. Micro violence are typically non-violent behaviors or behaviors that are not illegal but still threatening. So that could be bullying in the workplace, microaggressions, threats to your license, things like that, that aren't necessarily illegal, but still damaging. Other types of workplace violence are categorized by who the victim and perpetrator are. So there's 4 different types of workplace violence, victim perpetrator domains. The first one is criminal intent. So that's when somebody specifically comes because of a criminal reason. So that could be theft, or specifically they come to your office to for a physical assault, so with criminal intent. So that means they're probably not a client, might just be somebody from the community at large who is at your office to commit a criminal act. The one we probably think most about is the client or customer on worker. So that would be a client on clinician violence. So a client would commit a act of violence against a clinician. The other type is worker on worker, so clinician against clinician. Those tend to be more of what we just talked about in the micro violence, the bullying and the microaggressions. And then there's the personal relationship where it's somebody that the worker knows outside of their job, but is not connected to their job. So it could be a spouse, a family member, a friend who comes into a place of business and commits an act of workplace violence, but they're not actually associated with that workplace. So according to the Department of Labor and Statistics, and this is kind of an old statistic, so this may look different now, customer client workplace violence accounts for 28% of all incidents of workplace violence for healthcare workers. So the rest of them are either criminal intent, worker on worker, or personal relationships. So it's a really small portion of the workplace violence incidents, but they're the ones that get the most attention. So now we're going to kind of talk about some statistics and incidents around workplace violence and mental health. Some of these statistics are kind of dated. They come from the Department of Labor and Statistics, or OSHA, and they don't update their statistics very often. Also, mental health workers tend to be thrown in with healthcare workers when we're talking about incidences of workplace violence. So not all of the statistics apply specifically to mental health care workers only. So according to the CDC, the Center for Disease Control, 20,050 workers in private industries experienced workplace violence. So that's across all industries. There were about 20,000 incidents of workplace violence that were reported to the CDC. The U.S. Bureau of Labor and Statistics found in 2020 that 8,500, almost 8,600 healthcare workers experienced a non-fatal intentional workplace injury that required at least 1 day away from work. So out of looking at those two numbers, a large chunk of healthcare workers are experiencing workplace violence. So the chart to the side kind of shows different industries and the incidence of non-fatal workplace injuries. So this would be obviously anything that doesn't cause death, and that is reported to the Bureau of Labor and Statistics. The first column in that is the service industry, but right next to it is healthcare workers. And so they account for a large portion of the workplace violence incidents that are reported to the U.S. Bureau of Labor and Statistics. Here's another chart that kind of illustrates it, that while under 20% of all workplace injuries happen in the workplace, it happened to healthcare workers, they suffer 50% of the assaults. So while we experience a smaller portion of injuries or workplace violence incidents, we are disproportionately experiencing assaults as compared to other industries. So looking kind of at this chart, we're seeing a trend of healthcare workers being put in more dangerous situations where they are suffering assaults at a higher rate than other industries who also are experiencing workplace violence. According to the Occupational Safety and Health Administration statistics, so these came out in 2015. The report was published in 2016. So again, these are about 10 years old. 10.2% of all workplace violence incidents occurred in healthcare. And again, however, healthcare workers suffered 50% of all workplace assaults. So again, disproportionate number of incidents compared to how many of those incidents are assault incidents. OSHA also noted that workplace violence incidents are underreported, so the actual number is probably much higher. So these are only the incidents that were reported to OSHA, and there's to gather for statistical analysis. So the previous stats we just talked about included all healthcare workers, doctors, nurses, CNAs, but also mental health care workers. So now we're going to focus in on a couple studies that are specifically geared towards mental health workers. There are very few studies that examine workplace violence specifically in the mental health field. I had a lot of trouble finding some recent statistics or being able to verify through multiple studies what those statistics are. So I'm including a couple that I found. And again, these are just examples of some of the studies that were conducted and maybe not completely conducive of the full picture of workplace violence and mental health fields. So according to the APA Advisory Committee, this would have been in 2012, so again, a little bit older statistic, 15 to 25% of psychologists are at risk of being physically assaulted by a client specifically during their career. This article also indicated that serious injury is rare, but they didn't elaborate on how many incidents of workplace violence are serious versus how many are considered non-serious. And also any kind of assault, whether it results in serious injury, can have a huge psychological effect. So that part was also not addressed in the study of what percentage of psychologists may not have experienced a serious injury, but did experience a significant mental health issue from the assault. A little bit more recent study in 2023 found that 75% of counselors surveyed reported experiencing at least one incidence of workplace violence. And again, counselors had indicated they experienced psychological forms of workplace violence at a higher rates than physical. So they're reporting harassment, verbal abuse, bullying, and threatening at a higher rate than physical assaults. But 75% of counselors are saying they are experiencing some type of workplace violence in their career. So again, workplace violence can be found in any setting. It includes private practice, inpatient units, behavioral units, and schools. So across the board, counselors and mental health professionals are experiencing workplace violence in any setting that they're working at. Again, according to that study we just cited in the previous slide, 79% of workplace violence was reported within the first 10 years of a practitioner's career, with 55% reporting them in having the workplace violence incidents occur in their training program. So there's a few reasons that that happens. Obviously, when someone is newer in their career, they may not have the training or skills yet to know how to de-escalate and manage behavioral issues within their client interactions. Also, training programs oftentimes do not provide new counselors with tools and knowledge of how to deal with workplace violence incidents. And a lot of times earlier in our career, we're working in behavioral units or community mental health units, or places where there isn't as much security, or we're dealing with a higher acuity population. So in addition to the risks that all healthcare workers face when working with the public, mental health professionals have specific risks associated with how we conduct our business. And these are unique to the mental health field, and just some considerations to take into account. So some of the risks for the counseling profession, so the risk of physical danger According to Muncie in 2008, mental health professionals are at a moderate risk for experiencing physical violence. So again, this includes risks from clients, coworkers, and the community at large. So we're definitely not at the low end of it, but we're also not experiencing as much violence as a police officer or somebody who works more with the community at large. But we're still in the moderate range, which needs attention in our policies and procedures for our organizations. And again, we have the risk of psychological danger, verbal abuse, threats, harassments, and mental health professionals that are high risk for this. So when we're considering our policies and procedures around workplace violence, we also need to consider the physical workplace violence and not just the, I'm sorry, the psychological workplace violence and not just the physical. Some of the reasons for this increased risk for mental health workers is just the nature of our work. We work behind closed doors alone with clients, and so that does increase our risk of violence because we're not working out in the public. Also, some of our clinicians provide in-home services, which also puts you at a risk because you're entering someone else's space, usually without a knowledge of who else lives in the home, if there are weapons in the home, how the home is set up. You can't really have an evacuation plan because you aren't familiar with the layout of the home. So that definitely increases the risk of violence or the risk of being put in a situation that feels dangerous. Also, helping clients who are in crisis does put us at an elevated risk for workplace violence. There's no correlation between mental health conditions and increased aggression or physical assaults, but we are working with clients who are experiencing some crisis. And so that does heighten the risk for them being agitated, emotionally distressed, and that would increase our risk of the psychological forms of abuse. Also, the intimate nature of counseling relationships increases boundary issues between clients and therapists. Some clients may be confused about the counseling relationship and assume that there's an intimacy there that's not. And when they find out that that intimacy is not there, sometimes that can create some agitation. And then we also have risks for people who aren't even our clients. Family members can also pose a risk to mental health providers. For example, you're meeting with somebody as an individual who's considering divorce, tells their spouse that they would like a divorce, and that spouse could blame the therapist or feel like the therapist is responsible, and then act on that. So we also have risks that we may not even realize because we're dealing with people, and those people go back into their communities and go back into their homes. And some of the people who they are in contact with may have some animosity towards you as a mental health provider, especially if they feel like you are not helping them or doing a good job. So again, very rare, but something to consider. So it's just some organizational factors that increase workplace violence for mental health providers. The biggest one is just not having a standard plan or policies around ways to reduce workplace violence and also how to respond to it. If we don't have a good plan in place, it increases our risk for an incident to escalate or for more incidents to happen. So really that's the biggest organizational factor that's going to increase workplace violence. Also, a lack of training. So we may have a policy or procedure in place, but people aren't aware of them. They're not trained in them. They don't know like an evacuation plan or how to handle if there is a client experiencing a psychotic break or a client who is exhibiting physical intimidation. If they're not even aware of the policy in place, then they don't know how to respond. Also, of course, working understaffed. A lot of our hospitals, behavioral units, residential treatment programs obviously run understaffed quite a bit, and that increases workplace violence incidents because there isn't enough staff on site to manage the number of clients that are there. Also, high turnover, that kind of goes back to the training. The more turnover we have, the more likely we are to not be able to provide the proper training as people are coming in and out. Also, unrestricted movement from the public. OSHA noted that clinics and offices, hospitals are often open to the public, and so people coming in, we may not be able to have a say on who comes in or out of our space, because again, public hospitals are public and people can walk in and out of them as they need, unless it's a locked unit. So that does increase the risk because we don't really have control over who's coming into the space. So we'll spend quite a bit of time in this section of creating a safe workplace, kind of some policies, procedures for consideration. This is really just meant to be kind of a rough guideline or outline, things to consider. Definitely not a comprehensive plan by any means, just some things to take note of for your own organization, and some things to take back and kind of think about how some of these ideas might work in your space. So the best response to workplace violence is a proactive approach in which a clinician has a sound policy and procedure in place to not only manage safety issues, but also work to prevent them and de-escalate any issues that occur. Clinicians also must be thoroughly trained on how to implement these safety plans when they're needed. So thinking about having a more proactive approach to how we're going to deal with workplace violence will help us decrease those incidents. And when the incidents do happen, limit the escalation of them and hopefully limit the impact of them on clients and clinicians. So in an institutional setting, there's probably already a sound policy in place regarding how to deal with workplace violence incidents, how to de-escalate behaviors, how to communicate about safety issues. That is probably already in place. So if you're working in an institutional setting, just making sure you're familiar with the policies and procedures, also refreshing your memory every once in a while to remind yourself of this is the path or the policy that I follow if experiencing a workplace violence incident. And then making sure you ask questions to clarify those policies, and learning what resources are available at your location. And again, trying to do this often, as obviously things at an institution can change, and making sure that you have the most updated policy of safety in your knowledge base. So where we're going to spend a little bit more time is if you have a group setting or a private practice setting that doesn't already have those institutional policies in place. So just some things to consider as you are looking at your office space and considering different safety measures. Here are just some ideas to think about when you're looking at safety issues within your specific location. So one of the things you want to think about is, how is my office set up? Kind of look around your office and say, what kinds of safety issues are present in this? So thinking about where you're sitting versus where your client is sitting, you want to sit closest to the door so that you can leave if needed easier. So kind of looking at your office space and placing yourself closer to the door than the client. Also, just kind of making sure you look around your office and any potential dangerous items aren't just out for clients to grab, like a letter opener, heavy objects, just kind of keeping those out of reach. And then making sure your exit is clear and readily available. Again, sitting closer to the exit if you can. Also knowing after you get out of your office, the most direct way to get out of the building if need be, the most direct way to get to help. Also considering how your setup is with regards to how people get in and out of your space. Making sure that there's some kind of locked door somewhere. So whether or not a client has to be buzzed into the waiting room, or from the waiting room, they have to be let into the office space. So really making sure clients can't freely walk throughout the office, that you have a system where clients either need to, again, be let into the waiting room by administrative staff or the therapist, or they need to be let into the office area where the therapy rooms are by office staff. Also kind of considering installing video monitoring in common areas, either in the hallway or the waiting rooms, where if you need to review the video footage, you can. The second part of the policies and procedures that need attention is creating a really good communication method. So how are we going to communicate about safety issues proactively during and after an incident? So thinking about, if I am in with a client and I need help, how am I going to let people know, and who am I going to let know? So it's vitally important to create a method for communicating safety issues to others, especially if you're in a private practice or group setting. Again, if you're in an institutional setting, there is probably already a communication system in place, whether it's a panic button or that we have more than one practitioner in the room at a time. Whatever their communication system is, there is probably one in place. However, when we're in a private practice setting or a group setting, those communication practices probably aren't set up, or if they are, maybe not everyone's aware of them. So really considering, how, again, am I going to communicate to somebody else if I need help? So there's a couple different ways you could do this. One is considering developing a code word, which would allow you to ask for help discreetly, something you can either text or call or say to another clinician so they know that you need help. There's also some apps you could do that through, where you can communicate with the whole office discreetly, where you can send out a message to everyone that says, hey, I need help in room whatever, and then people being able to respond to that. Again, you could use a panic button, like they would use in an institutional setting. That may not be feasible or realistic for your practice, but if you're working alone, that might be a good option, where you could contact the police directly through some kind of button or easy means. Also, think about keeping your cell phone close to you. I know we don't want to obviously be on our cell phones during session, but kind of having it close to you that you could text or call discreetly or easily. Also, we want to give our colleagues permission to interrupt session if needed. If they are hearing something that they're concerned about, or if they feel like there could be a safety issue and need to check on you, allowing colleagues to interrupt session if needed is also a way to communicate better proactively. Also, if you know that a client is a potential safety risk or you're concerned about them, letting your colleagues know before the session when it is, what your concerns are, and then how you will communicate to them if you need something, just so they're aware of that potential safety issue. And then we want to make a response plan. So while we hope nothing ever happens, we want to have a clear plan in place for if and when something does. So we want to create a very sound and a sound policy of how we're going to manage the safety concern, and thinking through what do we need to include in this. So what I used to look at how a plan is created and what things to consider, OSHA has a guideline for mental health and healthcare workers of things to consider, and a safety plan of what types of factors could contribute to workplace violence, and then helping to write down that plan. So OSHA has a pretty good guide and pretty comprehensive guide of how to create a really good plan for your specific organization. So in their guidelines, OSHA included some different components that a safety plan should have. One should be again, the communication. How are we going to communicate safety concerns before, after, and during the fact? Also having an evacuation plan. So where are the exits? How do people get out? Where do we go through? So there isn't chaos if we need to get out of the building, that people can reasonably get out of the building safely as well. And then how are we going to report violence when it happens? There also needs to be a standard action plan for violent incidents. And so that should include the availability of assistance and how we're going to respond to concerns so that people have an idea of what's going to happen when a workplace violence incident occurs, so that in a crisis, they don't have to figure out what they're doing. They just follow the steps. And then after the fact, how to obtain medical or psychological care in case of a workplace violence incident, just so people are aware of the resources that are available to them. So again, OSHA provides a comprehensive guide on preventing workplace violence for social workers and healthcare workers. I included the link here in case you want to look at it. It's about a 60 or 80-page guideline, but it does include some of those risk factors we talked about. It has a little bit more information around them, a little bit more comprehensive analysis of different risks that healthcare workers face. The violence prevention programs, so things that they have identified that are already in place that you can utilize. Also safety and health training. So they have in there a guide for how to train your staff, how to communicate with staff about safety issues. And then they also have in that guide a program evaluation that allows you to, after you have the safety program put into place, evaluate its effectiveness and if there's any need to change anything. So it helps you create it, train your employees in it, and then once you have it put in place, evaluate if it is doing what you need it to do. Again, that link is here. So if you want to take a look at it, it's a pretty good place to start in a very comprehensive guide as to what a workplace violence program can look like. So keeping that in mind. Just some other considerations, things to keep in mind that are specific to probably more of a private practice setting, but thinking about what time you were seeing clients. So you may consider only seeing new clients during the day, that you only do new patient appointments during the day when more people are at your building, or more, if you work in a group practice where more practitioners are around. So some clinicians may only do those new appointments during the daytime hours. Also, you can set up a screening process to screen for potential violence through the initial phone call or initial evaluation. And we're going to go through what that could look like a little bit more in the next section. Another thing that you can do is connect with community resources. So connecting with the local police department in your area could be a really valuable asset to you. One of the things that we did here at Resolve was had each location, the police department came in and looked at our space and talked to our staff about safety and concerns. So they will do a consultation and come by your office and kind of look at it and give you some suggestions and ideas of things to think about. They'll also help you think of some different ways to manage safety. They gave us some tips on how to develop a safety plan. They also talked about how police respond when we call 911, which was extremely helpful. So you know what's going to happen if there is an emergency situation and you call 911, how they in your community are going to respond to it, how you ask for a mental health unit if that's what you need to respond. Also, we had a community resource officer come to our office space, and it just helped to kind of get to know them. They got to know us and what kind of clients we worked with, and they offered also to walk us to our cars if we ever felt unsafe, circle the building if we ever needed them to do that. So it was really valuable to have that consultation and then to start to create that relationship, so that, again, you know what's going to happen if you call the police, but also you feel like you have that resource if you need it. So this last piece of creating a safety plan revolves around education and training. So like we stated earlier in the presentation, most assaults against mental health care workers are going to occur early in their careers. So it is really important that, especially with newer clinicians or clinicians in training or internship programs, that they have education and training around workplace violence and how to respond to it when an incident occurs. So all students and trainees should be made aware of risks of workplace violence and learn how to discuss these concerns in any workplace setting, including practicum and internship sites. So we want to empower students and trainees to ask those questions of, how does this organization deal with the safety concern? What's the evacuation plan? How do I communicate if I am feeling unsafe? Who do I communicate with? So that before they even start seeing clients in your space, they understand the policies and procedures around safety and preventing workplace violence. I know some of the local programs specifically have that in their training programs now of providing students with the knowledge around workplace violence, and also then asking their internship sites about how safety concerns are dealt with. So just making sure that our newest clinicians are being well educated, well trained, and we acknowledge that obviously earlier in your career is going to be harder to deal with a workplace violence incident when you don't have the skills or training to do so. So we really need to be aware of that and provide that to any students, trainees, anybody who is a newer clinician within our organization, and make sure they are comfortable with the policies and procedures in place and understand them. So like I mentioned earlier, there are a few screening instruments and tools that you can use to help you assess for workplace violence. And these tools can be used either at the initial screening process, in the initial session, or throughout your treatment with them. So again, one way to reduce workplace violence is to screen potential clients for violence and make sure that they are appropriate for this level of care. So if you're working in an outpatient setting, making sure that that client is appropriate for the level of care that you are providing, or being able to refer out if they need a higher level of care. So you can ask about safety concerns in the initial phone call. You can ask if there are any concerns about violence or any history of violence in an initial phone call. Some of the drawbacks to that could be, though, you're not going to be able to really fully assess the client on the phone. You might not get accurate information, obviously. Clients sometimes aren't fully forthcoming on that initial call. And you also don't have the opportunity to observe behaviors and affects. So when we get into the into the screening tools on the next few slides, a lot of the indicators of violence are things that the clinician is observing. So if you're only screening on the phone for potential violence, you are kind of missing some of those behavioral cues that are assessed in person. So again, you can also use a screening tool during the initial assessment or throughout treatment to screen for potential violence, so that then we can put the plan in place of what to do if a client is at higher risk of violence. So the first tool we're going to look at is the Community Care Violence Assessment Tool, or the VAT. So this is one that can be used in the initial session, or it can be a reassessment tool. So you can use it when you first meet the client, and then every few sessions or every 6 months, whatever feels appropriate to you. So it's made specifically for like inpatient or residential programs, but you can also modify it and use it for an outpatient or private practice setting, just to get an idea of the potential for the potential for violence. So what the VAT takes into account is the history of violence. So it's going to ask the client if they've ever had any history of violence that includes assaults or homicidal ideation, things like that. But it also then includes the clinician's observations of body language, any verbal threats, physical threats, confusion, agitation within the session. And those two things together will give you an idea of the risk of violence. So the vet is going to also ask questions about contributing factors that a client will identify. Here are things that will also contribute to potentially being at higher risk, whether or not they start a new medication, whether or not they're hungry, if they have an infection that's causing pain, that could also put someone at an increased risk for violence. Psychological factors, like if somebody identifies that being told to calm down really irritates them, or feeling a loss of control or fear, or feeling isolated, those types of things may increase their risk for violence. And then you're also going to talk about environmental needs. So what increases agitation for that person? Noise. Are they someone who's really sensitive to noise, and that a lot of noise around them will create agitation? Temperature, too many people around. So getting a good idea of environmental factors that can influence how a person responds. And then just activity, changes in routine, assistance to care. So some of those are more specific to residential treatment programs and not as specific to outpatient programs. But those are also in there. The other part of it is where you note de-escalation techniques that the client specifically identifies. So you will ask the client what helps them to feel calmer, when they're agitated, what coping skills do they use, and you'll note that as well. So you'll have the assessment of potential risk plus the physical, psychological, environmental, and activity factors that influence them, and also the de-escalation techniques that the client identifies. So it's a pretty comprehensive screening tool in that way. So as you score it, you get 1 point for every behavior that you note as the clinician, plus the history of violence. So when you score it, and I have a copy of what the screening tool looks like on the next slide. But higher scores indicate an increased risk for violence. A low score is considered 0. And so on that, the recommendation is just to continue to monitor for violence. No other strategies at that point need to be put into place. A moderate score is considered 1 to 3. So the recommendation with that is just to notify a manager that this particular client may be at an increased risk for violence, or just letting them know that this client might only be scheduled during the day because they're at a little bit higher risk. Also, you're going to go ahead and complete the de-escalation section if someone's scoring in the 1 to 3 range. So you have that plan in place for if they become agitated or if their risk increase. And then also make sure that there's a communication system in place. So knowing that this client is at a little bit higher risk, how are you going to communicate to your colleagues if you need help with this client? So it kind of gets you thinking proactively. A high score is 4 to 5, or a very high is 6+. So this is where you're going to kind of say, okay, this client may be a little bit more volatile, and I might need a more comprehensive plan in place for how am I going to specifically manage this client. So the recommendation for somebody who has a high score, again, is to alert staff. It also said meet in public if necessary, but that is probably for caseworkers if they're going into the home. Also, go ahead and start thinking about if this level of care is appropriate for the client, and thinking about other referral sources. Because if we can't keep someone safe in the space we're in, then we do need to probably refer them out. So thinking about that as well. And then I included a link to that form. Here is the form. I just did a quick screenshot of it. The first page is the history of violence and then the observed behaviors. The second page is the scoring sheet, and then that last page is the de-escalation and environmental factors. I also got a couple of tools from the CDC website that you can use. They're not specifically screening tools, they're just things that well, they are screening tools, but they're not forms that you fill out, they're just observations that you make. And so one of the ones that the CDC had on their website was called the Assault and Homicidal Danger Assessment Tool. And clinicians rate observations of the client, and also through a clinical interview, you're looking at the history of violence, drug or alcohol use, homicidal ideation, and level of social support. So this is the one that it looks like. And again, 1 through 5, 5 being very high, and it gives you typical indicators so you can kind of know what you're looking for. The next one is the STAMP. It's an acronym of 5 behavioral observations that help you assess someone's potential danger. So staring in eye contact, tone and volume of voice, anxiety, mumbling, and pacing. So the more cues and behaviors noted, the more at risk of violence that this particular client is. So here's the copy of the stamp from the CDC website. And so you're looking at these 5 components, and the more that someone has of these components, the more at risk they are for violence. So keeping in mind, if they are scoring high on this, that means maybe we need to implement our safety plan. The next section, we're going to talk about the ethical and legal considerations regarding workplace violence and mental health, just some things to keep in mind legally and ethically. Quick reminder, I am not a lawyer. Also, I don't work with a professional organization, so just making sure that anytime you have an ethical question that you're checking in with your state, malpractice, professional organization, legal experts. So one of the considerations with workplace violence is confidentiality. So responses to workplace violence will usually require a release of confidential information without the client's permission. So while we have a responsibility as mental health practitioners to protect confidential information, disclosure is allowed in this specific situation. So according to the APA, disclosure of information is permitted in situations where permitted by law for valid purpose, such as to protect the client, patient, psychologist, or others from harm. So you're allowed again to release confidential information in this instance. The ACA also has a provision in their code of ethics that says the general requirement that counselors keep information confidential does not apply when disclosure is required to protect clients or identified others from foreseeable harm, or when legal requirements demand that confidential information must be revealed. Same provision for the NSAW as well. They do note, however, in the National Association of Social Workers guidelines, that you can only release information directly relevant to the purpose of disclosure. So keeping that in mind of releasing the least amount of information possible to keep everyone safe. Of course, we have the duty to warn. So just a quick definition of the duty to warn arises when a patient has communicated an explicit threat of imminent serious physical harm or death to a clearly identified or identifiable victim or victims, and the patient has the apparent intent and ability to carry out such a threat. So this is a legal requirement. Both Kansas and Missouri have laws regarding duty to warn and mental health practitioners. So just take a moment to look up your specific state statute so you're familiar with it. And if you're unsure if you should break confidentiality or if there is a duty to warn, always consult other therapists, your malpractice insurance, professional organizations, and/or legal experts. Another thing to consider with regards specifically to violence in clients is informed consent. So it's important that on the onset and throughout treatment that we are informing clients of the limits of confidentiality. So if a situation arises in which we have to break confidentiality, we have already let them know that that could be a possibility. Both the APA, NSAW, and ACA all have provisions regarding informed consent and making sure clients know that confidential information can be disclosed if the client is a danger to themselves or others. Another ethical consideration is termination. So termination of a client is allowed when a mental health practitioner feels that their safety or other safety is in jeopardy. So according to the ACA, counselors may terminate counseling when in jeopardy of harm by the client or another person with whom the client has a relationship. So when we talked earlier about being at risk for violence from somebody the client is connected to, the ACA does have a provision that says if a family member or somebody that the client is connected to threatens you, you can end the counseling relationship. The APA also states that psychologists may terminate therapy when threatened or otherwise endangered by the client, patient, or other person with whom the client person has a relationship. So kind of the same provision. In addition, the APA also goes a step further in ethical termination. So usually we have to provide a termination session or pre-termination session when we're transferring services. But the APA says that where precluded by the action of a client or patient, meaning that these pre-termination sessions do not have to occur. So meaning psychologists do not have to complete a termination transfer session if the psychologist is threatened or endangered. You still need to contact the client, preferably in writing, informing them of that services are being terminated, and then providing appropriate alternative referrals. Again, always get consult if you are confused as to what direction to go in, or if there's a duty to warn, or if it's time to terminate services with that client. I also went ahead and just linked the professional codes of ethics in case you want to take a quick look at the provisions regarding informed consent, confidentiality, and ethical termination. So the last part of our presentation today goes through some other safety concerns to consider. Those are going to be things like fire, weather, and public health emergencies that maybe we sometimes don't think about as needing a plan around them. So the first one's fire. Clinicians should be aware of the fire escape plan. The plan should be posted in your building. You should know the evacuation plan, how to get out of the building quickly, and what to do in case of a fire if the fire alarm goes off. If you own your own space, you have to make sure that the fire safety equipment you have to follow local regulations and make sure you have fire safety equipment as required by your jurisdiction. Also eliminate fire hazards, just like make sure you unplug lamps, unplug space heaters, make sure you're not using damaged outlets, just kind of being aware of any concerns. If you have a kitchen, making sure that any fire safety, that there's fire safety precautions in that space as well. The U.S. Fire Administration also provides a free presentation that you can give to workers on workplace safety with regards to fire, and I included that link here as well. It is a short presentation through FEMA. Weather safety. So inclement weather is considered any unusual or severe weather event that impacts safe travel or day-to-day business operations. So that's winter weather, severe storms, natural disasters. So here in the Midwest, we're going to think probably about flooding, tornadoes, and winter weather as things we need to consider when we're making an inclement weather policy. So mental health professionals should have a clear policy regarding inclement weather, how you're going to handle if it is too dangerous to come in the office. So are we going to switch to telehealth? Are we going to cancel all sessions? Are cancellation policies still in effect? And how are counselors going to communicate to their clients and other staff if we are not able to make it in the office and when those decisions are made? So just making sure, especially as winter's coming sooner than we'd like, making sure those policies and procedures are in place and communicated to their clients. I personally we have a 24-hour cancellation policy at Resolve. So I personally make the decision if I'm going to switch to telehealth 24 hours in advance of a winter weather storm. And then that gives my clients the opportunity to reschedule their appointment if telehealth is not a good option for them. The last part, also with weather safety, we need to think about tornado. So we need to have a business plan, an emergency plan, where to take shelter, how to ensure everyone's there, and what to do after a tornado has passed. OSHA has a pretty good guideline for this. I included the link, and it has just some ideas on how to communicate safety, especially around different weather phenomena with employees and staff. The last consideration is public health emergencies. So what COVID showed us is we definitely need to have a guideline in place for if there's a public health emergency, and what we as professionals will do in that case. Again, OSHA has a great guideline for that as well, and they have specific guidelines for different public health emergencies. They have one for Ebola, Zika, COVID. So you can kind of take a look at those and see what kinds of policies and procedures would make sense for your office space. Also, it's important to check all local, state, and federal guidelines and just utilize those when you're developing your plan for public health emergencies. So I know we covered a lot of information today, so if you have questions about any of the information presented, please feel free to reach out to our office. Our phone number is here, or you can email us at kcresolve@gmail.com. I'm happy to share any resources or information with you if you have any questions about some of the information presented today. These are my references, the references that I utilize. There's a couple pages of those as well with the links in case you want to visit some of the websites that I utilize for this presentation. I definitely appreciate you attending. I hope that this was informative and got you thinking about some different options regarding safety in your workplace. And of course, if you have any questions, concerns, please reach out to our office. We're happy to help. Thanks so much.